I'm Debbie Silverstein. I'm the State Director of SPAN Ohio, and we are happy to be offering this program to you today. It's a very timely one. We need to take a look at what coronavirus has shown us about our healthcare system and what those implications are for public health policy and medical policy. The other thing that we want to look at is what are the characteristics of the countries that have dealt with this pandemic in a better manner. The United States leads the world in deaths per capita. This is not a good thing for the United States. This is not something that should be happening and nothing that we should be proud of. And it's a sad day that that has happened. We're very thrilled to have a speaker today, Dr. John Ross. He is one of our founding members. So he was there 20 years ago when we started SPAN Ohio. And, so he can tell us a little bit about that too. But and why we did that. But he has served as our secretary for the last 2 years. He's been on the executive board of SPAN Ohio, I think almost the whole 20 years. And he also served as the president of PNHP at one time. He did a term there. And he's currently the president of the Toledo or Lucas County Board of Health. So he has a degree in medicine as well as public health. So he's the guy that we want to talk to today. And with that, I'm going to turn it over to Dr. Ross.
So I guess this is going to be a longer talk than I would have hoped because I'm trying to cover a lot of ground here. One of the things that I'm going to return to over and over again in this talk today is the failure of trust. Our healthcare system has let us down. People know that we have a sickness care non-system, and in the middle of a pandemic, that's probably one of the worst things that could have happened to us. But one of the things I think that everybody who's on this call needs to understand that science is messy and incremental. We do not arrive at what we consider to be scientific accuracy other than through incremental attempts at looking at data, adding to that data. So there's no absolute scientific truth. There are higher and lower levels of probability that are based on statistical analysis. And often when we discuss our science and its accuracy, we do it in specialized meetings behind closed doors. So the general public never sees how messy that process is. And I think that by being dishonest about that, by not really being very clear to people that we're dishonest, it's a problem. Yeah, so basically we're building the plane while we're flying it. And, the parts are flying, the roadmap above us, we can barely look at it while we're trying to fly. That's what this COVID pandemic has been like for us. As the data has come out, remember, we were pretty remarkably quick in getting basic information about this virus. The Chinese released the genetic code for it within a couple of weeks of them having begun to experience the pandemic in Hubei province. So they were very generous with that science. And immediately our American scientists and others around the world began working on vaccines. And so this is a schematic of COVID-19. Basically, it's an envelope of proteins and some fatty material that's put together, and inside the squiggly line at the top you're looking at, that's the genetic material, which is an RNA. And now those spike proteins, which are the blue, are perfectly matched like a hand in glove to fit onto something called angiotensin converting enzyme 2 receptors. That's a mouthful. But anyway, angiotensin is a key chemical throughout our body. It basically helps to control blood flow to every organ in our body. So every cell along the linings of our blood vessels has this receptor on it. And when the virus gets into our bloodstream, it's going everywhere, which is one of the reasons why this is so devastating. And one of the places where there's a lot of these ACE receptors is in our respiratory tree and in our lungs. And that's probably one of the reasons why this thing has hit the lungs the hardest. So that virus gets into our cell, the little squiggly line reproduces all those parts by stealing the materials from our cell and produces more of itself, which then bursts out. Now you've got replicated viruses that are floating around in the bloodstream. And the body responds to that with its immune system. So there's kind of a multiple way that we attack. There are things called macrophages, which are these purple things on the upper left. They envelop pathogens. Those could be germs, could be viruses. Once it's broken down inside of that white blood cell, which is kind of the garbage man of our immune system, it uses chemicals to break down whatever it engulfs. It begins to communicate back and forth with receptor proteins with lymphocytes. And the T lymphocyte can convert itself into what's called a killer cell. And it'll go to the cells that are infected and it'll destroy those cells. And then the macrophages come along again and kind of clean up the mess over there too. In the meantime, another white blood cell, the B lymphocyte, begins to proliferate and produce antibodies. That's that little Y that you're looking at. And that little Y in the picture is perfectly designed to glom onto the spike protein. And so it covers it up. And now that receptor can't be grabbed onto by the virus, so it can't continue to get into our cells because it needs our cells to reproduce itself. In addition, this set of B lymphocytes differentiate into what are called memory cells. And those memory cells go to our bone marrow, our spleen, our lymph nodes, and they hide out there. And they remember these proteins, these foreign proteins from viruses and germs. And so if our body experiences those proteins again, the body immediately begins to make antibodies. So that's kind of natural immunity. So that's how we naturally get immune. Now, this time, at least in America, we've mainly been using these messenger RNA vaccines. Now, messenger RNA is a temporary thing inside of our cells. It's what our cell uses to code and gather up the parts it needs to make the proteins that the cell needs. So they're very temporary. If they were long lasting within the cell, you'd have so many extra amounts of protein, the cell would become dysfunctional. So they're only existent for a very short time in the cell to do a very specific task to make a specific protein. Now, what we can do now is we can sit down at a computer and type in the genetic alphabet. These are what are called nucleotides. And if you string those out in the proper way, once you have the code, you can actually make a messenger RNA that codes for the production of the spike protein. So when we inject that into your muscles, those cells begin to produce this spike protein, and your immune system looks at it as if it's the virus and begins to respond to that and make antibodies. So the body produces the spike protein, your immune system kicks in and produces the antibodies. So these vaccines in many ways are almost miraculous. People who think, how do they do it so quick? Well, remember, science is incremental. We've been working on mRNA vaccines for a long time. If you go back and actually look at the history of these things, they've been used in veterinary medicine for over a decade. Actually, at the time when the coronavirus hit, they were working on maybe trying to create an mRNA vaccine for Ebola. So they were in the middle of it. All of a sudden, we've got the genetic code for this virus, and Moderna and Pfizer, who had the equipment to begin producing this mRNA vaccine, immediately turned away from other projects and began working on making, within weeks, literally within weeks, an mRNA that would code for the spike protein. They began experimenting on it within a month or so in individuals to see if it would produce immunity. Then they had to do a slightly bigger test to see whether it produced enough immunity to prevent disease in a smaller number of people and to look for any potential side effects and to adjust dose to know what the dose was. And then they did a large study. These are phase 1, 2, and 3 studies. That's how we do things. In the third study, you got to do a real big one in the real world. And these vaccines were proven to be about 95% effective, meaning that you did not get seriously ill or end up in the hospital or die when you got infected with the original virus. So the thing to understand, I think, is more down toward the middle of this next slide, that what we're really getting is what's called disease immunity. It's not absolutely protecting us from infection. What it's doing is reducing the severity of infection to the point where you don't get sick at all. So you may have no symptoms, but while you don't have symptoms, you still might be producing enough live virus that you can spread it to others. So even if you're not sick, you can give it to other people, even if you don't get seriously ill. In some people, if their immune system doesn't take to the vaccine or they have a damaged immune system, they may still not get enough antibodies to prevent getting very sick or even ending up in the hospital and dying from this. So even immunized people could die, but we know, at least with the original virus, 95% effective against ending up in the hospital or dying. So these are disease immunity vaccines. They reduce but do not eliminate the potential for disease, and there's still some risk associated with catching the virus. Now, what this is a graph from the CDC at their COVIDnet site. And what it's showing is the waves of different types of virus that we've seen over the last 2 years. And what you can see in here is that from the colors is that in general, at the very tippy top, you're seeing that little bit of color that's either gray or orangish yellow. That's young people 17 and under. So this virus has mainly hit people as adults in terms of ending up in the hospital, because that's what we're looking at as cumulative hospitalizations. And we got the vaccine out relatively quickly. So we were beginning to immunize people by the time the big hump there in the summer was coming along. We had started in November with nursing home patients, physicians and nurses, safety workers, ambulance drivers. Those are the sort of people we were immunizing between November and January of 2021. So that's about the middle of this graph. And you can see that the disease began to come down. But then toward the end here in August, September of 21, we had the Delta, which was a new variant and was a little more resistant to our antibodies and was more infectious. So we began to see a spike again, once again in adults, but you can see since we were doing a really good job getting seniors and age 65 and up vaccinated, and even 50 and up more vaccinated than younger people, all of a sudden we've got a whole lot of younger people ending up in the hospital. And then the very last spike, that's Omicron, which is even more infectious and more resistant to the original vaccination, even if you were boosted. So the vaccinations were actually pretty miraculous. Commonwealth Fund estimates that we probably through to November would have had at least an additional 1 million COVID deaths and more than 10 million additional hospitalizations had we not been vaccinating people throughout this early period. So we actually were pretty fortunate that we had the science and technology to rapidly make an effective vaccine, which is remarkably safe and remarkably effective. Unfortunately, less effective against these new variants. Oh, and so this was interesting as well. This is from an article published by Commonwealth as well. And what they were showing, and this only goes through November, through the Delta wave. So we've got a whole nother spike that's off the end of this graph. But this is two models. What would have happened if we didn't have the vaccinations? And that's the red line in terms of a 7-day rolling average of deaths in our population. And what happened with the green if everybody had been vaccinated. So you can see how valuable this vaccination process was. Now, I'm going to move on here, I think, in a minute, but one more slide here, because I want to show effectiveness again in a moment from these. But the cost of the failure to vaccinate was extreme. So just in this one last wave, we saw $14 billion worth of hospitalizations that did not have to happen if we had gotten people vaccinated. And if you take the next spike, which was the Omicron, which is not on here because it happened in late December through January and now into early February, what we've got is an amazing amount of money we're going to spend picking up the pieces because people didn't trust us. I'm going to go back to that. I'm going to return to that point again, is that the key thing here is somehow along the line, we as physicians, nurses, public health people have lost the trust of the nation. And we because of that failure of trust, have ended up with this tremendous slaughter of our fellow citizens that was probably unnecessary and with tremendous costs, and the economic costs aren't even in here. This is just the cost from the hospitalizations. So here's what you can see. Even though we don't have absolute data on this, that's what these little brackets are, is the ranges that we think, statistical ranges that we think is accurate. So with Delta, which is that second to last bump on that graph of hospitalizations, we can see that overall, if you'd had the normal set of vaccinations, 2 doses, it was about 82% effective. So if one was you weren't vaccinated at all, what's the chance you'd get seriously ill and land in the hospital? It was at least 82%. And then if you had a booster dose, it was 85% effective for keeping you out of the hospital. And remember, the original one was 95. So we lost some potency because the virus was able to mutate. And I'll talk about that in a moment about these mutations. But Omicron, a little even less effective, but still, if you were boosted, 81% effectiveness and keeping people out of the hospital. And fortunately, it's turned out that Omicron also Perhaps it's because it's infecting more young people, but the bottom line is that we've had fewer deaths from Omicron. People have ended up in the hospital just as much or more, but it's been less likely if they ended up in the hospital that they were going to die. We still don't know the long-term consequences from all of this. So I'm going to shift now because I think one of our failures here is to understand how important public health is in this role. And just to do a quick review of how public health works, because it's not the same as medical care and it's not the same as vaccination. We're assessing and looking at the environment in our communities all the time. So we're monitoring the health. If we see a sudden jump in respiratory illnesses, maybe it's a flu, or maybe it's a new variant again of the flu that could be giving us trouble. It's our job then to diagnose and investigate. And often those things are handed off to state health department labs or the CDC to figure out what's going on. We have to inform, educate, and empower our communities and mobilize our communities. I can tell you when the COVID landed in Cleveland, we were already convening all the civic leaders in our community to talk with them about what it was going to mean if this virus, given its infectiousness, was going to hit our community. And we began shutting down theaters. We began shutting down music. We began shutting down restaurants. You know, we were talking about it before the cases even showed up in Toledo. And within about a week, we had our first death in Toledo from this virus after about a week after Cleveland was showing it. So that's our job, is to mobilize the community and let them know what we're about to face. And we could see that we had a terrible storm coming for us. And then another aspect of our job is to develop policies. You know, for example, how close, it sounds silly, but how close can your septic system be to your home? Those sort of things, the safety of the septic system might depend on it. Our job is to go out and look at new septic systems that were being put in, make sure they're being put in right. We're water quality, air quality, a lot of things where we're involved in enforcing the law. And then we have to assure that we have a competent healthcare workforce in our community. In our community, we actually audit and certify our obstetrical units. That's our role as far as the hospitals are concerned. And then once again, we go around this circle and evaluate. Linking people to medical care or providing medical care is only a small part of what public health does. So it's one of these many aspects. So that's kind of all based on research and trying to manage the system. So I'm going to jump into talking a little bit about the social determinants of health. And many of you probably are familiar with this, but I'm going to make this point as best I can. So you've got policies and programs and health factors that result in outcomes. And the outcomes we want is to improve length of life and the quality of life. And when we actually go back and look at what makes a difference for length of life and quality of life, it's only about 20% clinical care. That's that little box in the middle, whether you can get access to care, access to quality care. And embedded in all of that are a whole bunch of other things that are usually public health's responsibility, including regulating and dealing with tobacco use and helping people to get off of nicotine, advice about diet and exercise, making walkable communities, exercisable communities, dealing with alcohol and substance abuse and trying to prevent the harms from that, advising on safe sex and trying to prevent the harms from unsafe sex, including HIV, hepatitis, and sexually transmitted diseases like syphilis and gonorrhea. That's all in our bailiwick. And then the economic factors, like a good education system and how does it function within your community, employment security, income security, family and social supports and community safety, air and water quality and housing and traffic. Access to good housing, access to available transportation that's affordable, all those things play a role in whether somebody has a long life and a quality life. And 80% of that business sits more in the public health domain than it does in the clinical care domain. So we have to pay attention to public health. And as part of our health reform, it is absolutely key that we deeply embed public health and clinical care with each other. There should be no wrong door. It doesn't matter what door you walk into. If you're seeing the doctor, that doctor ought to be able to plug you into social services like housing support or transportation or family and social supports if you happen to need those, because that's going to make a difference in the effectiveness of our clinical care. When people don't have their other social needs met, the ability for them to stay healthy or to get the services that they need, are only 20% of what's going to keep them healthy. So we need to have no wrong door. Similarly, if they're walking into social services and don't have healthcare, there needs to be a way to quickly connect them with actual medical care as well or clinical care. So these social determinants have come very much to the fore in this COVID-19 pandemic. What you can see here, I won't go, it's a busy slide, I won't go into it, but you can see all these areas again: environmental and physical safety, food security, housing, social supports, transportation, language and cultural differences. Those all are parts of what we're seeing that affected who got sick with this COVID-19 pandemic. And only access to healthcare, that's a small piece, again, 20% of determining who had the worst time, the worst go of it. When we shut things down, obviously people who didn't have income security, who lost their jobs, people who couldn't get to the doctor or did not have safe transportation. All those things are kind of part of what COVID did to us, to really emphasize and show us how important these social determinants were for who got sick and who didn't get sick in a pandemic. So public health's job is to pull all these different things together, to hold together the additional social services along with the clinical care like doctors, hospitals, community health centers. But we've got to knit this web together, and it needs to be deeply integrated with these other aspects of our communities if we're actually going to have the healthiest nation. And so what we've learned both from this pandemic, and we've also learned from our clinical care experiences within our community, is that collaboration, not competition, is the way we're going to get the best health outcomes. And we've got a whole healthcare system that is built on hospital systems and physicians in a competitive mode based on market ideologies rather than collaboration based on social cohesion. And we need to have a system that's based on collaboration. And if we're going to compete, we should be competing against disease and disability. We should not be competing against the hospital across the city or, among doctor groups. Collaboration is the answer, not competition when it comes to healthcare. And we'll get better quality and better effectiveness if we do it that way. So I'm going to show you kind of how much we're actually spending on public health here for a moment. Now, remember, we're spending about $4 trillion a year now on healthcare in the US. And so far, the public official estimates of spending on public health have been about 80 billion, which would be about 2% of our total healthcare spending. Remember, 80% is the social determinants. 2% is being spent on public health. To me, that doesn't make a lot of sense. When we actually look at how much of the spending is going toward those key things that we talked about, it's really only about half of it. So we're really spending 1% of our total healthcare budget on what determines 80% of whether we're healthy or not. Now, there's probably, you can only have so many people digging in one spot before they start hitting each other with their own shovels and chopping off each other's toes in the process of trying to dig. So I don't know that money alone is the solution here, but I can tell you that more money wouldn't hurt, and deeply embedding that public health money, integrating it with our clinical care is the way we're going to get the best outcomes. So now I'm going to back up here and I'm going to try to do this quick, but it's important to remember that in health reform, which is why we're here to talk today, we've been at this for 100 years, more than 100 years. Teddy Roosevelt had already been president. He was running for president again after going over to Germany and seeing all these social programs, including a national health program that was in place per Kaiser Wilhelm and Bismarck. And he proposed in his campaign, that was the Progressive Party, Bonmoose Party campaign, that we have national health insurance in the US. And, I'm going to go back there, but just looking at this picture, anything German by the end of the 2010s through 1910s through 1920 wasn't going anywhere. I think, here we got these guys in their gas masks and helmets and everything else. So we'll go back to this sort of pathway. But when it came to the New Deal, Franklin Roosevelt had thought he would like to do national health insurance as part of the New Deal. We're in the middle of a depression. He was going to get Social Security passed. He got workers' compensation passed. He got works projects to get people working again. But he was talked out of doing national health insurance by his friend, Dr. Morris Fishbein, who was head of the AMA. Truman, throughout the end of World War II, he tried twice in that 1940 through 1952 period to actually pass national health insurance. We had legislation. We had first the Wagner Health Act in the Senate in the late 1930s, and then we actually had the Wagner-Murray-Dingle bill in the 1940s, but we failed. One of the other things that was going on in Truman's era there was the growth of unionism, and also the fact that we linked our health insurance to our jobs, because during World War II, there were wage and price controls, but there weren't benefit controls, and there was a shortage of workers. So the way we ended up with having our health care as working people hooked to our job was through an accident of World War II wage and price controls. Now, we came into the 1960s debating health insurance, Nixon and Kennedy. After Kennedy was assassinated, Lyndon Johnson, who was very savvy, he'd been a senator and a rep, and very much understood the legislative process, had dirt on just about all the powerful people in Washington, D.C., and he was able to work with Wilbur Mills to get a Medicare passed. It's a wonderful history. Medicaid was a secondary issue. The AMA wasn't thinking much about poor people, but it was old people and poor people who couldn't get covered, because old people, the insurers didn't want to cover them. They were going to get sick. Poor people didn't have any money to buy insurance. So it was quite a success in a major incremental national program. So we got old people covered. We got poor people covered. We can argue about how effective that has been, but it wasn't the way the right wing wanted to do it. When we came into the Nixon era, he was just looking to control costs, and he had heard that HMOs, reduce care and therefore save money, and that was his proposal. And I'll show you kind of a little sweep of history after that and on a different side. But we still had a tremendous number of people uninsured in the era when Clinton came on board. We had 50 million people uninsured in America. He had said that he wanted to do a universal system, but he was a rookie and didn't understand that the second most powerful people in Washington, D.C. are committee chair people. And he forgot to get them involved in the process. He sent Hillary into a back room with some experts. They came out with a plan. There was no buy-in from any of the committee chairs, and it went nowhere. They did manage to get some incremental success later on in terms of expanding children's health insurance under the CHIP program. Obama, a little more sophisticated guy again. He had been a legislator, came in understanding who the second most powerful people in Washington, D.C. were. And all he did was say, I'm willing to spend up to $100 billion to cover more people, bring me a bill. And that process was by the skin of the teeth. After Ted Kennedy died, we got the ACA. It was not the best bill among the bills that were potentially going to be passed, but we didn't have the people in the Senate to actually prevent a filibuster. And then we got a whole era of opposition to the Affordable Care Act. Even though it covered 20 million people, we had this whole opposition from the right wing. They had multiple votes to repeal. Then Trump came on, he was going to repeal and replace, but they had no replacement. And ultimately, John McCain did thumbs down. And we ended up keeping, after a battle now in the Supreme Court as well, the Affordable Care Act. So this has been dancing on knife's edge now for a decade, whether we would continue to use the ACA to cover people. So what's next? So you remember these guys, right? So now we got these guys. All right. So we had a war going on in World War I that kind of got in the way. And now here we got a different kind of war, a war against a virus that's been very deadly, a different set of personal protection than the German soldiers had, and a different set of weapons to fight. But we do have more weapons to fight this thing now. We've got some new drugs that are very effective, keeping people out of the hospital. I won't go into the detail. If people want to ask about that later, I will. So why are we all messed up about health reform anyway? What's the deal here? Well, our costs are out of control. Our outcomes of care are mediocre or even poor compared to other rich countries. Access to care is going downhill, even for people with health insurance. We still have 30 million people uninsured, despite the Affordable Care Act. We've got 90 million underinsured who are at risk of either medical bankruptcy or self-rationing their care because of high costs. And we've got a sickness care non-system in the middle of a pandemic. I mean, that's why we got to be talking about this stuff and about how we can do better. If nothing else, we need to learn from our experience. So here I'm going to show you kind of the cost comparisons. These are even worse. We're now spending almost $12,000 per person per year. The other countries are spending a little bit more. But as you can see, our public spending, which is the yellow, is almost enough to give us an excellent national health insurance program without adding in the orange, which is our private spending. So how is it that we're spending all this money? The theory has been that, I got two more things here. had things a little bit out of order in my brain here, but I just want to show you that some of the basic indexes of how we're doing in terms of our outcomes are not all that great. So if you look at our life expectancy, we're about 6 years under the best over here. And that doesn't seem like much, but believe me, a lot of young people have to die for us to be that far behind in our life expectancy here in the US. So we are, and the data shows that. And our infant mortality, this is deaths in the first year of life. That has a tremendous impact on our longevity. Obviously, you're losing 80 years of life when somebody dies in the first year. And if we look at this, we're consistently and have been over decades now behind in infant mortality, which is, everybody agrees is kind of an index of the effectiveness of the healthcare system. And if we look at treatable mortality, that is the diseases where we have good treatment, effective treatment to prevent people from dying, we've been behind now for almost 2 decades. The red line is up at the top. We have more deaths per 100,000 from treatable illness than these other countries do. And if you look there, that purple line, that I believe is the United Kingdom, which is kind of, the poster child for a national health service. So anyway, we can do better. And our treatable mortality, we have the doctors, the nurses, the hospitals, the medications, the equipment we need. What we don't have is a system to give the best treatment that's available to everybody in our country. We need a system. So again, these costs that we have, which are almost double everybody else's, are affecting everyone, including those that are insured. If we look at people who have health insurance, we're seeing people relying on over-the-counter meds, skipping dental checkups, postponing needed care, skipping a recommended med test or treatment, or actually having trouble getting mental health. And half of Americans are now experiencing one of those sort of above things, and 13% say that because they've been skipping, their health got worse. So it's not surprising that our outcomes are mediocre. Now, when it comes to COVID, once again, we're seeing these social determinants show up. In this case, it's racial disparities and ethnic disparities, as well as economic disparities. So this is a study that showed early in the pandemic that people with fever and cough and also probably suspected that they had COVID, weren't getting care. So if you look at all adults, we had about 14% of people with fever and cough who did not seek care because of cost barriers early in this pandemic. And then we had a second group of folks, and you'll see that this was highly differentiated by racial disparities, much more likely if you were non-white to not get the care that you needed when you had fever, cough, and suspected COVID. And what do you think that did to the spread of this disease? And then let's look at the next set, which is income. And again, those with more modest incomes, even those with high incomes, were skipping care because they said of the cost barriers. So now the question is, how pervasive is this? It's pretty much across the board, but it was especially troublesome for people over the age of 65, because that's where we were seeing excess mortality throughout this pandemic. So we had basically people of color who were low income, who caught it in the teeth the worst from this, partly because our system discriminates by cost, and the other social determinants of health, including being old, being more likely to be socially isolated, and more likely to be unable to get to the doctor. Now, the reason we're expensive is not because we get more healthcare. US actually, in terms of hospital days per person per year, we're low, not high on that. Now, that's our most expensive thing that we do is end up in the hospital, but that doesn't seem to be a driver of the cost. We also get fewer visits. So a third of what they're getting in other countries in some situations. It's not too many doctor visits, but that's the theory that we've been told, is that we need to have people pay out of pocket because they're getting too much care, they're getting unnecessary care. What we actually see behind the scenes on all of this is the tremendous growth in the number of non-clinical people in healthcare. So the number of people that are administrators or managers or never dealing with the actual patient or their illness has grown 4,000% over the last 50 years. Down at the bottom, that yellow line is the growth in the number of physicians. And if you superimpose the nurses, it would be just a little bit below that yellow line in terms of the growth of actual clinical personnel. So we have a jobs program for paper pushers because the healthcare system is so complex. So the disease of our healthcare system is its hyper complexity in its finances and the way we fund it and organize it. So I want to show you here. Remember, I talked about Nixon coming up with HMOs because they were going to save money. So you can see the HMO Act was passed in the 1970s, the early 1970s. Right about that same time, Canada was completing its evolution from provincial to a national health program that was organized and run through each province. And what you can see is as we hit about that same time, when Canadian Medicare, they call their national health insurance program Medicare, just like we call our senior program Medicare, you can see that all of a sudden the effect on their GDP flattened out. It did grow, and it's grown across all the other rich democracies as well, but we went off the charts. And what happened that took us off the charts is suddenly we had market forces and competing private health insurance agencies that were running our healthcare system. And the administrative costs of that have been tremendous. So that's that growth of administrators. It's built right into that ever increasing percentage of our GDP, which makes all of the products that we want to sell overseas more expensive, and it actually damages our economy. When we look just the insurance overhead piece, we're spending almost $1,000 per person per year more than the Canadians just on insurance overhead. Now, this is kind of a schema of our national health program as it's currently organized under the Affordable Care Act. Why does it look like such a hell of a mess, or a mell of a hess, as one of my patients used to say? It's a mell of a hess because it's so complex. We got provider lists and doctor lists and different levels of plans and different co-payments, and trying to sign up for Obamacare was, you'll remember, was kind of a disaster. If you're trying to do it online, you look down at the left there, you could end up getting diverted by cat videos or orca attacks. And of course, we were out there advocating during Obamacare's debate for a single payer national health insurance program based on an improved expanded Medicare for all, but we didn't get it. Now, the GOP, better known as gouge the old and poor, their plan for insurance was get sick, die penniless. They still don't have a plan, even though they still are saying we should be repealing and replacing Obamacare. So I want to go back and look at what they think is going to work. Now, they told us that good old market forces were the cure for American healthcare costs. So how's that been working for us? Here's the list. I can tell you the first time I started putting this slide in presentations, there were half as many of these. Okay, so HMOs, managed care, capitation to try and control costs on the clinical side. They privatized because, of course, private sector is way more efficient than the government, they say. Privatization of Medicare in the form of Medicare Advantage. It used to be called Medicare Plus Choice. It was less choice. So they changed the name on that one. I'll talk about another name change at the bottom of this list. And Medicaid, completely pushed into managed care organizations now. I think almost 70% of Medicaid across the country is all in managed care. And they came up with the idea of privatizing certain facilities like nursing homes, went from being more charitable and or nonprofit organizations. Home health care used to be totally not for profit in our county here. It's now divided among a whole bunch of for-profit agencies. And then facilities like dialysis, all have gone toward profit. They said that people needed to have more skin in the game. They had to pay more, and that would make them more careful. Well, of course, it doesn't. There's plenty of data to show that high co-payments are just barriers to care and don't improve care. And health savings accounts was one of those ideas, or high deductible health plans, where you'd have a more skin in the game, and we know who's getting skinned, and it ain't a game. They said we needed exchanges like insurance exchanges or insurance markets across state lines, or allow small businesses to associate and buy health plans together. All those things are out there and being tried. Bundled payments, where you would make the doctors and hospitals agree to a single price, and then they share the money behind the scenes for things like hip replacement or a knee replacement. Pay for performance has been tried, not just in the US, but it's been tried in Europe. No real effect on costs. All the money that you save by that pressure on performance pretty much gets eaten up by administrative costs, trying to figure out whether you're performing well or not. You got these new things called accountable care organizations, which are basically HMOs of sorts, but they passed it down to the hospital and doctors to congregate together and put all the restrictions in. A Cadillac tax, the theory was, we're too insured. We have too much insurance, so you should be paying more again. That was part of Obamacare. High risk pools to take the really sick people out so the premiums be lower for the average person. Big part at the beginning of Obamacare, not effective. Malpractice reforms. This is a holy grail for doctors, right? The only reason we're ordering all these extra tests is because we're worried about being sued. Well, almost every state in the country now has had pretty dramatic malpractice reforms to reduce the amount that doctors get pay out if they actually get sued. Hasn't affected our costs. Price transparency is one of the more recent ones where they're saying that hospitals have to publish their prices, but a lot of the most expensive things are buy or die. If you've got a heart attack, you're not going to go in and haggle with the cardiologist as he's about to do a heart cath on you to try and see if you can get him down 20% on the price. It just doesn't make any sense at all. And the most expensive things are the things that are the most urgent and the least optional. So basically, it's like highway robbery, your money or your life. And lastly, now they're trying to privatize Medicare in a different way than managed care and as in a Medicare Advantage, renamed from Medicare Plus Choice to Medicare Advantage, right? So if they say Advantage, you're probably disadvantaged, just like Medicare Plus Choice was less choice. But now we've got direct contracting entities. And this is Wall Street buying doctors behind the scenes and then basically enforcing rules to make them act like Medicare Advantage plans. And the seniors aren't being warned or explained or understood that this is happening to them solely through the choice of their physician. And their response to it is, oh, you don't like this idea, then choose another physician. But one of the most important things that people care about, A, for developing trust, B, for quality of care, is continuity of care with their physician. And all the different doctor lists and hospital lists are breaking up that continuity and making our care less satisfactory. That was a long one, I apologize. So here's the boys, and it's almost always the boys. And these are the guys in the health insurance companies that don't want change. Why would you want change when you're making $10 to $30 million a year? You can go ahead and give plenty of money and you can divert money from your corporation, since corporations are people now and can speak with their money, and money is speech. They can buy the best Congress money can buy. Now, this is interesting because this is the lady, Chiquita Brooks LaSure, who's the administrator for the Center for Medicare and Medicaid Services, and she oversees all of Medicare and Medicaid. That's about 150 million plus people. We're paying her about 200 grand, a little more. We can get good people to do this work for less than $20 million a year. We do not need to pay these guys that kind of money. It's preposterous. So keeping it simple, keeping it understandable is a key part of what we need to do. And we don't need to pay that kind of money to get good administration within our healthcare system, let alone the $2 or $3 million, sometimes more, we're paying hospital CEOs. So again, the other problem we've got is this sort of craziness where, unlike the rest of the world, we won't negotiate on drug prices. That's preposterous. The government negotiates for pencils, for staplers, for reams of paper, and we can't negotiate for medication for seniors. And it's also completely anti-market oriented. So what they've done is they say, no, you got to have a middle person, a pharmacy benefit manager, who are now under investigation for their sort of fraudulent and dishonest behavior as the go-between between our seniors and their medications. And they also work with health insurers as well. So if we look at the costs of our drugs, double that of most of the other European democracies that provide universal care. So way too much money being spent on medications. And again, guess what? It's the boys. Here they are smiling away. The one guy there for Regeneron looks like he's the cat that ate the canary. $120 million a year. He's the dude that authorized Trump to get his antibody treatment before it was actually authorized by the FDA. So you've got lots of sort of connections between the profiteers and our politicians. Now, are these guys worth it? There's the question. There's an organization that is a group of political economists who have looked at CEO pay. And what they say is that since 1978, it's up 1,322%. Okay, so 13-fold increase in CEO pay. And there's nothing within their education or skill set that has changed over that period of time that or any evidence of increased productivity on their part to justify this kind of rate of increase. And when we first started looking at this in the 70s, it was 100 times more than the average worker that CEOs were being paid, and now it's 351 times. So this isn't just in our healthcare system. There's this sort of rapacious, hyper-profiting, some economists call it rent-seeking behavior, where because they're in that position, they can demand that the corporations pay them more. And how is this affecting everybody? Well, obviously, this isn't the only thing, but here we are with our families trying to get insurance through work, and family premiums have gone up way more than workers' earnings and even more than inflation. So, built into almost everything is this excessiveness of payments, all through the management of healthcare and all through the management of our corporation in the corporate world. So here's my heroes. Hopefully your heroes too, if you're on this. Bernie and Pramila, that's Bernie Sanders and Pramila Jayapal. They're the people that are carrying our national health insurance bills, our improved expanded Medicare for all bills in the US. And at this point, we have more House members signing on as co-sponsors than we've ever had in the history of our efforts. So we're making incremental progress, at least in terms of turning the politicians around. And why do we think that an improved expanded Medicare for all is the medical care model? It's simple. Everybody in, nobody out. You don't have to ask whether you're covered. You are. Everybody's covered with comprehensive benefits. It's efficient. We saw that the efficiency is terrible in our current system with all those managers. Way less management needed when you've got a very efficient system such as an improved expanded Medicare for all. I'll show you some more data in a second on that. Got limited or no out-of-pocket barriers, which we saw was key for making people skip care, including even people who were coming down with COVID. And you can do the cost control, but you don't do it with market forces. You do it by giving budgets. The way we do cost control in our own homes, we kind of set a household budget and we try to stick to it. Always have to have a little reserves. Things happen. When COVID could have happened and we would have needed to dip into the piggy bank. But the bottom line is we can do cost control using budgeting. And we can have fair financing. Right now, for example, that's those CEOs who are making $10 and $20 million a year probably have a secretary who's being paid maybe 50, right? And they're taking the same amount of money away from her for healthcare as they're taking away from the CEO. They're both paying the family premium, which is about $22,000 a year. So the bottom line on it is that the upside down financing, and who gets the tax benefit? Well, higher income group gets a higher deduction for having that money not come directly to their pocket. So all the tax benefits are going to the rich, and the rich are having a much lower portion of their income dedicated to covering healthcare costs. Even a flat tax would be more fair. And we, under an improved expanded Medicare for all, we would have complete choice of provider. There might be a few physicians and Park Avenue psychiatrists or whatever who would step outside and insist on private pay. But I don't think it's going to be enough to be significant, and neither did the CBO when they looked at this. So CBO has now done an analysis of kind of a version, their imagined version of how Bernie's bill would roll out. And what they found is looking at their data, and it's a very extensive 200-page report. It was published in December of 2020, if you want to look it up, how CBO analyzes single payer. And what they said is that right now, private health insurance is spending 12% on administration. I think that's probably a little low from what I've read from other sources, but that's what they said. And they were picking kind of their best guess. The 8% on Medicare includes all these private sector things. If you actually look at fee-for-service Medicare, it's 2%. And when they said, well, let's do what Bernie's asking, what would our insurance overhead be? They said probably 1.6%. So we've got about at least 10% of our $4 trillion that we can save. Do the math. That's $400 billion on insurance savings alone, just on the health insurance administrative side. And then on the doctor and hospital side, you have all that complexity. It becomes much more simple. You budget the hospitals. They didn't do that they assumed that the hospitals would continue to bill. So there's extra savings there. And in doctors' offices, the overheads were about proportionate to what you saw with the insurance overhead when I showed you that slide about Canada. So here's kind of a schema that the CBO, they actually did 5 of these because they looked at schemas where people had out-of-pocket payments, and we're very much against out-of-pocket payments. They would keep people from getting care, but they don't make the care better. There's lots of data on that now. Basically, high out-of-pocket payments make people sick and kill them. So we don't want to go there. So these are the scenarios where there would be very low out-of-pocket payments. It also simplifies. I used to say, my office, it costs me just as much to collect $10 at the window as to collect the entire fee at the window. And so the overheads of a copay for a patient magnify my overheads as well, because it doesn't matter whether I have to collect $5 or $20 or $50, it's the same amount of work at the window. Anyway, so copayments kill. These are programs that the CBO analyzed without copays. And they looked at what they call low provider payment. Now, low provider payments, this was all providers, including drugs. So, they let the drug companies get away with more than we would probably allow them to get away with in a negotiation. But for provider payments that were low in this scenario, what they were targeted at was about what we're getting now. So they're saying, well, you're going to have administrative expenses, so you could afford to take about a 10% fee cut and still be held whole. So that's low provider payments. High provider payments is we don't take those administrative savings back from you. We let you keep them. In the low provider payment, we end up saving $650 billion a year, $658 billion a year if we went to that low provider payment. If we give all that overhead to the doctors as just cash to put in their pocket, and the hospitals cash to put in their pocket, and the drug companies cash to put in their pocket, then we save $42 billion. So even if we give them like a jackpot, we're still going to save $42 billion a year on national health expenditures by going to an improved, expanded Medicare for all. And that doesn't even include the savings we would get if we budgeted hospitals, which is what's in the Jayapal bill. So what does that allow us to do? The last scenario, if we went somewhere in between, we'd have enough savings from that $650 billion. We could take part of it and use it to pay for long-term care for everybody. So we could have it all. We could have the best healthcare system in the world. We've already got the best doctors, the best nurses, the best hospitals, the best equipment. What we don't have is a system that allows people simple, affordable, and universal access. And this would allow us to do it. And indeed, that's what the CBO says. There's one area that they kind of moan about. They say, well, if everybody doesn't have copays, then people are all going to come crowding into the healthcare system. And the evidence suggests that's just bogus. What we know is when Canada did this, they didn't have lines, in terms of as they made significant expansions. Actually, what happened was the rich got fewer visits and the poor got more. Why is that? Because the poor are sicker than the rich. So you didn't have to do a wallet biopsy anymore in Quebec, where they actually did a very detailed study of this. We saw this in Taiwan, who went to a single payer in 1995. They brought on almost 40% of their population and didn't end up with lines. And we as doctors, we know how to triage. So we can figure out, and I did it all the time in my office when I got too busy. I'd call Mrs. Smith, who was well-controlled hypertensive, mainly worried well, and ask her to move her appointment off a week so I could take on somebody who called in the morning and said they were really sick, so I could see them the same day. So these are same-day appointments. And this, for us, the US, it's our insured. We don't have any data on the uninsured that it's reliable. So even there, we're okay. 51% of us can get an appointment the next day if we need it, the same day or next day if we need it. Some countries are better, a few aren't quite as good, but it's pretty much comparable across the world. But what we have is a whole bunch of people who have infinite waits. And the CBO did not average that in at all when they were looking at their theories of congestion and or in the fairness of the program. So I go back and I look at this. Every religious tradition, large religious tradition in the world, and even some of the smaller ones, you can go back and find this. Actually, the list would be 2 pages if I put it up. But we've actually got, a notion that we should do to others what we would want to do for us. And I mean, after all, we dug Saddam Hussein out of his rat hole, and our best army doctors fixed him up just so we could hang him. Who should we deny decent health care to? I can't think of anyone. One of my colleagues said the criteria for whether you should have coverage for your health is, can you fog a mirror? So I think that's how we should behave. It's not for us as caregivers to judge the value of that person's humanity. It's our job to take care of whoever comes before us with compassion. So I think the golden rule here, healthcare should be a human right, especially in a country as rich as the US. Now I'm back to trust again. And I think that one of the things that is breaking down trust is that caregivers and others among us are not fighting for a system that is universal, simple, and affordable and fairly financed. What's the matter with us that we won't do that for our friends and neighbors? And I think that that's played a tremendous role in kind of pre-pandemic damaging our trust. Now, they've actually studied this. There was a big article in Lancet where they looked across countries, and they found that the single most highly associated reason for failed public health efforts to control COVID-19 was loss of government and loss of interpersonal trust. So when they assessed those things, that seemed to have more of a statistically significant effect on how well a country did with its COVID control. And obviously, from our public health infrastructure, we're probably the worst among the rich countries. And we're among the worst in terms of the rich countries, in terms of interpersonal trust and trust in our government. And it's essential to any, I wouldn't even say caregiver relationship, any human relationship that's a positive one. Trust is essential to it. And trust is very hard to build up and very easy to tear down. And our research on patient trust in their provider shows that that's been deteriorating in the US. And although most of our patients are unaware of how doctors get paid, the exact methods, they're very distrustful of methods that discourage medical use. And yet those are the incentives of the commercial insurers. And we've seen what that means in terms of their profits and our barriers to care. So people are catching up. This is coming along pretty steady, drip, drip, drip. We have more and more people who are saying that the government should be responsible for making sure that everybody gets health care. Even a third we're below a third before, we're a little above a third in Republicans and people who lean Republican. And overall, across the entire country, we've got about 2/3 of Americans who think the government needs to assure that everybody gets health care. And among those who are Democrats, we're up to almost 90%. I mean, 10% of people think Elvis is still alive. So it's like, come on, it's time to do this. So I'm just going to read this for you. This is Frederick Douglass, who was talking about the battle against slavery. But to some extent, I think, he was talking about human rights. And I think we're talking about human rights this morning. And he was talking about the struggle against slavery. But I think this quote applies just as much to our battle to try and get a decent healthcare system for everybody in this country. This struggle may be a moral one, it may be a physical one, and it may be a moral and physical one, but it must be a struggle. Power concedes nothing without a demand. It never did, and it never will. Find out just what any people will quietly submit to, and you will have found out the exact measure of injustice and wrong which will be imposed upon them. And I think that's where we're at right now. I'm going to go back for 1 second here and talk about the latest market forces, which is direct contracting again, because they're talking about changing the name. That's what our battle. We went to Washington, D.C. with petitions. Physicians from all over the country, activists from all over the country are worried about these direct contracting entities eating away at the fee-for-service Medicare system and applying these rationing principles to patient care. And they want to change the name. That's the concession that they're willing to give. So we got to demand better. I mean, I saw from our PNHP leader, Susan Rogers, physician, internist in Chicago, she said, not good enough. All right. Changing the name doesn't change the motivations. We have to make it very clear that market forces will never improve or make our healthcare system better. It's collaboration and cooperation that's going to work, and focusing on social and determinants of health every bit or more than we're focusing on the clinical care side. So that's my talk, gang. I didn't have time to follow the chat. If there's questions, I'm going to stay on just as long as you want to answer them. So thanks, Deb. Thanks, everyone.